Okay, good evening. We would like to welcome you all in another webinar, and that is on TFOS Dues 2 and the management protocol for dry eye disease. To begin with, I would like to invite the president of AIOS to speak a few words.
Thank you very much, Rajesh. Good evening, everyone. Hope all of you are safe and sound and stay healthy. I think this is something very important, that we are passing through a difficult time and we need to actually keep ourselves engaged, whether it is academically, scientifically, or culturally, and we need to keep our spirits high, because this storm will pass one day, but we need to emerge stronger out of this adverse situation that we are in today. So AIOS has been conducting a lot of webinars over the last couple of weeks to keep you engaged and to enrich you with knowledge over various subjects. And today we have experts who are going to be talking about the tear film ocular surface. So we have experts from the Tear Film Ocular Surface Society. And Dr. Virender Sangwan, whom you all know, he's somebody who's a pioneer, who's actually, I would say, the father of stem cell transplantation, etc. In India. And then we have Dr. Bhaskar Srinivasan, who's also extensively worked on the, along with the society, as also Dr. Geeta Iyer. I think Dr. Namta will join us soon. So without much ado, I think this is an interesting topic. There are a number of cases of dry eye, people coming with grittiness, etc. Have all increased. The computer vision syndrome, the other problems, drugs, etc., as also the environmental pollution is all adding to making this a modality that making this a disease entity that we all should know about. And as you can see that over the last couple of years, there has been a plethora of treatment options that have been there. So without much ado, I think we will go into this webinar, and I hope that it is enriching to all of you. And over to Dr. Rajesh Sinha, who is a professor of ophthalmology at the RP Center, works in the cornea anterior segment division. So he will be taking it over from here. Professor Rajesh Sinha.
Thank you, sir. And we begin the webinar, and we know we have Dr. Virender Sangwan, who was a part of task force of TFOS Dues 2, and we are fortunate that we will be having the introductory lecture, the introduction about TFOS Dues 2 from Dr. Virender Sangwan.
Thank you, Rajesh. Can I share my screen?
Yes, sir. Yeah.
I think I'm fine. Is my slides visible now?
Yes, sir. Yes, sir, it is visible.
Okay.
Yeah.
All right. Just a minute. Yeah.
Yes, perfect. Yeah.
So we're talking about Dues 2 report and the overview, the management principles. I'll give a very brief introduction, how it started, what we did as part of this steering committee. I have no financial interest or conflict of interest with the material being presented. The Tear Film Ocular Surface Society Dry Eye Workshop brought 150 clinician, basic scientists from around the world, and they put the data together and screened all the studies from around the world. And the report, the work started in March of 2015 in San Francisco. And then we met several times in the next 2 years. The report was finally published in September in 2017, Ocular Surface, the journal called Ocular Surface. A brief history: the first international conference on lacrimal gland and tear film and dry eye syndromes was organized in 1992. 95, there was the first NEI report, and these are all landmark reports which has laid down the guidelines and basis for research and treatment plans. 2004, the Dues 1 was constituted, and 2007 the first report came, and then the Dues 2 reports came in 2017. So what were the objectives of the Dues 2? Update the definition, classification and diagnosis of the dry eye disease, critically assess the etiology, mechanism, distribution and impact of this disorder, and address its management and therapy. There were 13 subcommittees, which were clinicians based on their interest, experience, and publication history were divided into, and these are all listed here. And each of them brought out a separate subcommittee report, and then this was also published. And then there was an overall report of all the subcommittees, which is called harmonized report. These were the steering committee members, which we were about 15 doctors and clinician scientists from around the world, first met in San Francisco. And from there on, this DUSE 2 process started. Thank you very much. And Rajesh, you can invite the next person.
Thank you, sir, for a nice and crisp introduction on TFOS DUSE 2. And now I would like to invite Dr. Geeta Iyer. Now I would like to invite Dr. Geeta Iyer, who will be talking about understanding, definition, and classification and unmet needs of dry eye.
A very good evening to one and all of you. Thank you, Dr. Rajesh, and thanks to the AIOS for having provided us TFOS National Ambassadors with this platform for sharing this capsule on dry eye disease. So whenever you talk about a disease, you start at the very beginning, and the definition of the disease should be able to give you the gist of the entire disease in a single sentence. And the classification should give you a broad overview and perspective of the disease in its entirety. For the uninitiated, the TFOS DUSE 2 steering committee basically wanted to provide an evidence-based approach and a process of open communication, dialogue, and transparency in order to achieve a consensus concerning multiple aspects of dry eye disease. And just as mentioned by Dr. Sangwan, there were 12 subcommittees, and the ones which have been highlighted in color are the ones that we are going to be talking about today, and I will be focusing on the definition and classification subcommittee. And this subcommittee basically aimed to create an evidence-based definition and a contemporary classification system for dry eye disease. So what exactly did they do? They started from the previous dry eye definitions and classification schemes, making revisions to address what were perceived as shortcomings in the earlier versions using a consensus-based manner. And the members supported the need for a change in the definition as well as a more simpler definition, one that would help us differentiate dry eye disease from other ocular surface diseases, that would resolve confusion between diagnostic versus pathophysiological features, acknowledge the multitude of etiological triggers, and recognize the role of neurosensory abnormalities in dry eye disease. So this was the revised definition that was drafted by the TFOS DUSE 2. And when you read it like this and look at it like this, it appears as dry as the disease that it aims to define. So let's make it more simpler and a little more interesting to understand what each and every word in this definition means. So it was decided to carry on the terminology of dry eye, despite the fact that you have paradoxical wet dry eyes in a majority of these patients, mainly because the term dry eye had already gained significant global recognition and acceptance. It is multifactorial because there's no single characteristic sign or symptom that defines this condition, nor is there a single etiopathological factor of this particular topic that we are discussing now. Considering the impact of the condition on the end organ that it causes, especially with respect to the structure and function, this does qualify for the terminology of being called as disease. And of course, the end organ itself, which is affected, which is the ocular surface, accompanied by ocular symptoms, which does not qualify the ocular symptoms in this definition, whereas in the previous version, you had specifically the visual disturbances and discomfort that was mentioned as part of the ocular symptoms. Therefore, keeping this open-ended, in order to include a wide variety of manifestations of symptoms that these patients usually present with. The subcommittee was actually very tempted to stop the definition of dry eye with just the first half of what is actually described, but they decided to have the second half to the definition, mainly to emphasize that these four factors, tear film instability, hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormalities, they play etiological roles and they are not mandatory diagnostic criteria, as was misinterpreted from the earlier version of the definition which was given in the TFOS DUES 1 report. And of course, the central pathophysiological concept of the entire definition lay in this phrase, loss of homeostasis of the tear film. And if you look at the evolution of the definition of dry eye over the years, disorder became disease, tear film hyperosmolarity and ocular surface inflammation changed from being mandatory diagnostic criteria to having causal etiologic roles, and the phrase loss of homeostasis is something new which has been added. So once we've actually understood the definition in its entirety, I think we can proceed forward to understanding the classification of dry eye disease, which again has undergone an evolution over the years. But if you look at the earlier classifications made in 1995 or in 2007, what was basically done was that it was classified into aqueous deficient and evaporative dry eye disease, which again gave a misperception that a particular patient had to be fitted into one of these two categories. The concept of having a mixed variety or a hybrid dry eye disease did not exist and was not made clear in the previous definition or the classification of dry eye, and especially to address this misperception of mutual exclusivity of dry eye disease subtypes, and in addition accommodate patients with a conflict between signs and symptoms, which is what we normally see when we are examining patients of dry eye in our OPD, and also to include an option for a diagnosis of so-called normal, the classification system was refined, because ultimately the aim or purpose of classifying any disease is to improve patient care. And when you look at the classification that was provided by the TFOS DUES report, again, when you take a look at it like this, it appears to be very daunting. So let's again break it down into smaller components and start from the bottom, which is what we are more familiar with. The division of dry eye disease into aqueous deficient and evaporative dry eye, but it is made very clear here, theoretically, visually, and pictorially, that these are not watertight compartments, and you can have patients who belong to either of these categories, and you can very well have what is called as a hybrid dry eye disease. So once we've understood this, let's look at the upper portion of the chart and break this down further. It's only this one particular drop down which leads you to the diagnosis of dry eye disease. So these are patients who have both symptoms as well as signs of ocular surface disease. But are they always dry eye? Well, we shall look at it in a little later in these slides. But when you have symptoms and signs, then they qualify for being termed as dry eye disease. When you look at the right corner, these are patients who are symptomatic but have no signs. So what does that mean? Either that these patients are yet to develop signs of dry eye, which means that this is a preclinical state of dry eye, and possibly if you keep following up these patients over a period of time, they would develop signs and therefore become qualified to be termed as patients who have dry eye disease. But there could also be another category over here, where these are patients who could probably be suffering from neuropathic pain and therefore have to be referred appropriately for pain management. Coming to the left side, you have patients who could be absolutely asymptomatic, who do not complain of anything, and you pick up the signs of ocular surface disease during the routine examination or during your preoperative screening. So these are patients who have no symptoms, but they have signs, which indicates that they are predisposed to dry eye. And under this, you also have the category of neurotrophic conditions, which explains the significant disparity between signs and symptoms. And on the extreme left is the group of patients who are neither symptomatic nor have signs, who are termed as normal and who obviously require no treatment. This particular group of patients has got more relevance, especially when you're conducting epidemiological studies or clinical trials, and not exactly important from the clinical perspective, where we are more interested in the patients who actually have a problem. And below each box, you have the particular subcommittee report that you need to refer to in case you want to go further with respect to understanding of what needs to be done further for that particular patient. So this is the classification that was proposed by the TFOS-induced report. And like I said, when you have patients who present to you with both symptoms and signs, it is not always necessary that they should only belong to the dry eye disease category. And here comes the importance of what is called as triaging questions, where you have a list of questions that are asked to the patient, which helps you differentiate between dry eye disease and mimics of dry eye disease. And once you have excluded those and you suspect dry eye, you do a risk factor analysis, and then you run these patients through the entire diagnostic methodology, which is going to be dealt with in detail by Dr. Bhaskar in the talk subsequently, which brings you to the end point where you will be able to put these patients into a category of either aqueous dry eye or the evaporative dry eye or the mixed variety. And once you have that categorization, there is another exhaustive list of differential diagnosis under each of these categories, which will help you narrow down your diagnosis in that particular patient based on the history and the investigations, both ocular as well as systemic. Which brings us to just a couple of slides on the pathophysiology of dry eye disease, wherein the TFOS primarily has been advocating through both its reports that be it aqueous dry eye or be it evaporative dry eye, the one final common pathway of dry eye disease is the tear hyperosmolarity, which leads to the other effects and manifestations that you see in these patients. Also very beautifully elaborated in this report are the various sources of dry eye symptoms and the causes for each of the symptoms that these patients present to you with. Of course, when you have a definition, when you have a classification system, there will always be another group or another team that comes out with another definition or classification with which you will have to compare and contrast the definition that you have proposed. And the one significant group which has a slightly different viewpoint is the Asia Dry Eye Study Group, which defines dry eye slightly differently, where they state that it is the unstable tear film which is pivotal, and unlike hyperosmolarity, which is proposed by the TFOS, and they go more by the breakup patterns in patients with dry eye, which has given rise to their thought process of tear film oriented diagnosis and tear film oriented therapy, in contrast to the used to diagnosis and classification and concept of treatment, which is what I have tried to highlight in this particular slide. So this brings us to the fact that there are, of course, unmet needs. Starting right from the definition, it's only when you have these differences, it's probably because of the fact that you have geographical variations, you have maybe ethnic differences, you have manifestations of the disease which are different in different parts of the world, and therefore there is what we call as unmet needs of dry eye, which not only exists as far as the definition of the disease is concerned, but we probably also need to work on algorithms to help us narrow the diagnosis down further. You're going to be hearing about investigational tools, but we need to understand their relevance, the need, and the inference of what we derive from these various investigations and how to apply them clinically, as well as more research with respect to the various management options which are in the pipeline with respect to this particular disease, that which will be dealt with in the subsequent talks. So to connect definition and classification of the disease is concerned, what it helps us do is categorize patients into whether you have dry eye disease or whether you're normal, you have other ocular surface disorders, which could be mimics, whether you have neuropathic pain, neurotrophic keratitis, or whether it's a preclinical dry eye. If it's dry eye disease, is the patient symptomatic or asymptomatic, which justifies the conflict between signs and symptoms, and helps you categorize these patients into subtypes: aqueous deficient dry eye, evaporative dry eye, or hybrid disease. And what all this basically aims, that this particular approach is not really intended to override our clinical assessment or judgment, but rather it helps guide clinical management and future research. With this, I conclude my talk, and I thank you all for a very patient hearing. Thank you.
Thank you, Dr. Geeta. It was very nicely done classification, and it's so essential to know dry eye is just not a disease which is that simple. There are so many things into it, and that's what TFOS used to has explained about dry eye. So we now move on to the next speaker, and that is Dr. Bhaskar Srinivasan, who will discuss about the investigational tools for dry eye.
I think the best part was that you also discussed the Japanese group classification, which people don't amalgamate generally. The Japanese people, you know, they advocate their classification, and the TFOS Jews to group does its own classification.
I think it's important to understand that each of them have their own, you know, it has their own pros and cons. Each of them is not complete by itself, and we probably have to take the best and consider a revision in probably the further revisions that the TFOS plans for.
We look forward to Dr. Sangwan to be doing it.
Sure.
Can I share my slide?
Yeah, please.
Please do, please do. We were waiting for you to share. That's why we were talking.
Thank you. Thanks, Dr. Rajesh. And I would like to thank AIOS for giving us the platform to discuss the DUSE-2 report under the aegis of AIOS. So I would be covering the diagnostic tests, both clinical and investigational, that we do. I have no financial interests. So when you look at diagnostic tests, apart from our clinical evaluation, you have n number of tests that can be done and that are available now in the market, which helps you categorize dry eye. But do you need all these tests? Probably the answer is no. You do need a couple of them, but you need to use them judiciously. So this is probably the most important slide in my presentation. It basically talks about how you would want to approach this patient. So when a patient comes to you, the first thing that you would ask is a set of triaging questions to identify whether he has dry eye or he has some kind of a mimic which is similar to dry eye. Once that is done, then you put him through the risk factor analysis, and then you give the symptom scores, and then you look at the tests which are called as the homeostasis markers. So let's go through the questionnaire or the triaging questions. Basically, these are some of the normal questions that we ask our patients who come to us as to since when does he have the discomfort? Was it associated with any other issue, especially if it was associated with, say, with the conjunctivitis, and following which he developed dryness, or it was associated with a drug reaction, or it was associated with any change in medications that he had over the last couple of months. Generally, if it's medicine related, it's supposed to be within 3 months. Or if the patient has an itching, which is a predominant factor, which indicates allergy to be more of a role, play more of a role rather than dry eye, even though we do know allergy and dry eye can coexist. But once you have gone through the triaging questions and you feel that, yes, this patient has dry eye, and you want to evaluate the patient further, you give the symptomatology score or the symptom questionnaire. And once you do that, then you go on to the homeostasis markers. The homeostasis markers basically are the non-invasive or the invasive tear breakup, which tells you about the stability of the tears, the tear osmolarity, and the ocular surface staining score. Now, this is what has been recommended by the DUSE-2. But in a practical situation, in a real world scenario, not everybody would have the option of using a tear osmometer because it is an expensive tool. So in an Indian context, it would be probably, we would be adding the Shermer's strips to this diagnostic test kit to give us our diagnosis of dry eye. So when you look at the questionnaire, it needs to be a validated questionnaire, and generally it's administered at the time that the patient starts his evaluation in the clinic. And you have n number of questionnaires which are available in the published literature. But what has been recommended by the DUSE-2 is the OSDI and the DEQ-5. You also have the option of using something called as a Sanday symptom score, which could be used to assess the comfort of the patient pre and post interventions. The next important thing was the homeostasis test, of which the first one was the tear film stability. So you have two ways of measuring it, one using a non-invasive method and one using the invasive fluorescein breakup time. It's preferable to use the non-invasive because fluorescein will alter the tear film stability. Having said that, a non-invasive test is expensive. The normal values between a non-invasive test, what is taken is around 10 seconds, and this has about an 80% sensitivity and specificity. So machines like the Oculus keratograph can give you the non-invasive breakup time, and it also gives you a baggage of other information in terms of the tear meniscus height, meibography, and redness scores. So this is how a printout from a keratograph will look, where it shows you the area where the tear is breaking up faster, and it gives you the average in terms of the first breakup happened at what time and the average breakup, and it also classifies the dry eye based on the tear breakup scale. You also have equipments called, like the ocular surface analyzer, which adds on an interference fringe pattern to the diagnostic kit, and it gives you lipid layer thickness, tear meniscus height, breakup patterns, meibography, and redness score. And this is how the printout appears, where it gives you something like a traffic signal like approach, where the green is normal, the yellow is borderline, and the red is an abnormal value. So it becomes very easy for even the patient to understand that his value is borderline or his value is abnormal. You have investigations like the thermography and the tear evaporation rate. These are more in terms of research-based tools. They've not come into clinical practice as such. So at this point of time, the recommendation is that the non-invasive breakup is better than the fluorescein breakup, and the cutoff value that is to be used is 10 seconds. Coming to the next part in the homeostasis was the tear osmolarity, and we have the tear lab osmometer, which can help us identify the osmolarity of tears. The normal cutoff value is supposed to be around 308 milliosmoles per liter, but what is important is the difference between both the eyes. If the value between both the eyes is more than 8, difference is more than 8, then it indicates an unstable tear film. The value between both the eyes, what you would take is the higher value when you say a cutoff of 308. So it does show a reasonable amount of statistically significant results in as far as the Sjogren's patient is concerned. And the inter-eye variability of more than 8 is considered as a loss of homeostasis. So the next part in the homeostasis marker was the surface staining. And again, when you look at published literature, you have from the von Bischtaghal's scoring system to the latest ocular surface scoring system given by the Sjogren's International Study Group. You have various ways of grading the staining. It is important to follow the same grading system throughout, so you know what you're dealing with. So this is taken from the publication in AJO 2010 from the Sjogren's International Registry, where they grade less than between 1 to 5 spots as a grade 1 corneal staining, between 6 to 30 spots as a grade 2, and more than 30 spots as a grade 3 staining. Now, in addition, if there is confluent staining, if there is filaments, or if there is central visual axis involvement, it is given 1 point extra. So you have a total of 6 points for the cornea. For the conjunctiva, for both for the nasal and the temporal conjunctiva, you have 3 points based on the distribution of the staining pattern. So you get a total of 12 points per eye. And this could be used as a useful tool to follow up patients. So this is the representative picture of the conjunctival staining of a grade 1, which shows between 10 to 33 spots, a grade 2, which shows about 33 to 100 spots, and a grade 3, which is more than 100. You're not actually individually counting the spots. It's just the pattern and the patch of confluence that tells you an idea whether it is grade 2 or grade 3. The next, in our real world scenario, instead of the osmolarity, we said we would be looking at Schirmer's. So when you look at tear volume measurements, the two tests that stand out are the Schirmer's and the tear meniscus height. A Schirmer's value of less than 5 in 5 minutes is obviously indicative of dry eye. A value less than 10 can be borderline. You still need to evaluate the person further. The range of specificity and sensitivity is around 70%. A tear meniscus height can be measured with non-invasive measures like the keratograph or the OSA, or it could be measured once you put the fluorescein and you look at the patient in the slit lamp. You can actually evaluate the tear film height. What is important when you're measuring with a non-invasive equipment is to be careful that you don't measure the fluid above the chalasis, because if there is a conjunctival fold, your tear meniscus height might artificially look higher. So what is recommended is a non-invasive tear meniscus height measurement would be preferable. If you are using Schirmer's, it's preferable to use Schirmer's without anesthetic, especially if you're dealing with Sjogren's syndrome. However, if you're dealing with a predominant meibomian gland dysfunction, this might still be normal. Coming to the evaporative dry eye or the MGD, you have a set of clinical and diagnostic tests. The clinical test would be based on lid margin abnormality, quality and expressibility of the mebum. The diagnostic test would be to look at the anatomy of the meibomian gland and to measure the lipid layer thickness. So when you're looking at quality of mebum, you have a score of 0 to 24, and 0 is clear and 3 is toothpaste-like, and these are for 8 glands for both the eyes. As far as the expressibility is concerned, it's measured in 5 glands, where 0 is all glands are patent and 3 is no glands are patent, and then you add up for both the eyes. A LipiView is an interferometry-based tool which can help us identify the lipid layer thickness in a more quantitative manner. The OSA gives a range of the lipid layer, whereas LipiView gives you the absolute value as such. It also gives you the mebography, and it is able to give you the blink pattern in terms of how many times the blink was partial and how many times it was complete. Coming to mebography standalone equipments, by itself, any infrared camera can help you image the meibomian glands. You don't need very high definition equipments. Even your autoref can actually help you image the glands. So when you're looking at meibomian glands and looking at the anatomy of it, Arita et al. Gave a grading of grade 1 of MGD dropout was if it is less than 30%. Grade 2 was 1/3 to 2/3 loss, and grade 3 was more than 2/3 loss of meibomian gland structures. And now you do have automated grading systems, which makes it a lot more easier. So this is an example of a mebography with a moderate dropout, and when you look at this, you can see a complete, almost a complete dropout. But what is important is mebography alone cannot tell you about the extent of meibomian gland dysfunction, because it's only an anatomy. It doesn't tell you about the physiology. So you need to combine the imaging of the glands, you need to assess the lipid layer, and you need to look at the expressibility of the lipids before you come to the diagnosis of meibomian gland dysfunction and severity. Coming to the TFOS classification, which Geeta spoke about, it basically speaks of the timing of the break of the fluorescein. It speaks of the place of the break, and it speaks of the pattern of the break. So if you look at the figure A and D, this is what you would probably get in someone who has an aqueous deficiency dry eye. A spot break or a dimple break is seen in patients with what they call as decreased wettability. In this, basically, even when the tear film moves up from as you blink, it doesn't completely coat the surface, and that's why it's called as decreased wettability. And once the tear film forms, and then there is a random break of the tear film, it's supposed to be a evaporative dry eye. The reason they have classified it as this pattern is because they associated the aqueous deficiency with a decrease in aqueous tears, and you need to supplement the tears. If there is a decreased wettability, there's an issue with the mucin 16, which needs to be addressed either with ribepamide or daclofosol. Or if it's an evaporative dry eye, you would need to look at replacement of the lipid layer. Other investigational tools would be in terms of ocular surface inflammation, which could be either in the form of redness scores, which can be used to follow up, or it could be in the form of confocal, which can tell you the increased inflammatory cells in the epithelium and the anterior corneal stroma, or it could be the use of available kits like the MMP9 kits, which are there. But these are all non-specific markers of inflammation, not specific to dry eye per se. At this point of time, these are only investigational tools. Confocal can also be used to look at squamous metaplasia, nerve changes, and conjunctival goblet cell to address dry eye in a more holistic manner. And obviously, if you look at the sensitivity of the cornea, it helps us understand the discrepancy between symptoms and signs of the patient. The blink dynamics also play a major role, especially if somebody has an incomplete blink, it can cause surface staining and exposure keratopathy. So we need to look at all these patterns. So to conclude, the tests for the tear homeostasis are the most important of the tests that we do. A dry eye can occur even though there's no staining of the ocular surface, example like in an MGD patient. There is no single gold standard sign or symptom that correlates with the severity of the dry eye, and you need to have a combination of symptoms and tests to help us diagnose and grade the severity and help plan treatment strategies. Thank you.
Thank you, Dr. Bhaskar, for a very nice and comprehensive overview on what investigations we can do in cases of dry eye. You started from the very basics to the most advanced tools that are available currently for investigations and management of dry eye. Next, we move on to the next speaker, and that is Dr. Virendra Sangwan, who will be discussing about the broad guidelines for the management of dry eye. We will take the questions in the end after all the talks are over. So we move on to Dr. Virendra Sangwan.
Thank you, Rajesh. My slides are not moving. All right, yeah. So in terms of the management and therapy for the dry eye disease, what the dues to aimed was provide the guidelines as to how to achieve the homeostasis of the tear film and alleviate the ocular discomfort. Also, determination of the cause of dry eye disease is critical for selecting the most appropriate management strategy. And Bhaskar just now explained how do you do the investigations to delineate those things. Also, we should remember meibomian gland dysfunction is a major contributor to both the signs and symptoms of the dry eye. And failure to resolve the signs and symptoms of dry eye may relate to deficiency on underlying disease. So for me, when I see a dry eye patient, I just don't label it as dry eye. First look at whether there is a local or a systemic disease which is accounting for the symptoms. Like for example, if you have OCP, SJS, other cicatrizing conjunctivitis, VKC, AKC, rheumatoid arthritis, Sjogren syndrome, or any local factors. So DUES 2 proposed a 4-stage management algorithm that presented the stepwise approach for the management. And I will now talk to you about those management strategies. So this is essentially treatment for tear insufficiency, treatment of lid abnormalities, surgical approaches, dietary modification, if any, and anti-inflammatory therapy. The tear insufficiency you can address by tear replacement, tear conservation, or tear stimulation. Most frequently, all of us use is the tear replacement, which can be artificial tears, lubricant, biological supplements, or like autologous serum. And more infrequently, we do use punctal occlusion or moist chamber spectacles. Rarely we use topical secretagogues or oral secretagogues or nasal neurostimulation. Artificial tears, they are the mainstay for the dry eye therapy, and they attempt to replace or supplement the deficient tear natural film. Here we must understand that we are talking about a dry eye disease which is not associated with anything topical or a systemic or local disease. In that, we need to have a tear replacement strategy. In other diseases, it's only an adjunct to the main treatment. They are typically buffered solutions that contain electrolytes, surfactants, or one or more viscosity agents or lubricants. These products do not target the underlying pathophysiology of the disease, but they alleviate the symptoms. And also remember that there are very few or hardly any RCTs, randomized controlled trial, to compare the efficacy of the superiority of one agent versus the other in terms of the products. So we should remember that very important point. Then what are these ingredients of these? They are viscosity enhancing agents like CMC, HA, or CMC plus HA, variety of combination, osmotic agents, osmoprotectants, lipid supplements, preservatives, inactives like excipients, electrolytes, and then antioxidants. All the tear supplements what we have drops are a combination of one or many of these components. Osmotic agents, as we know, the hyperosmolarity is a common denominator for the dry eye disease, and it initiates a cascade of inflammation. So therefore, it's very obvious to use or correct the osmotic imbalance. So use of hypotonic, hyaluronic-based ocular lubricants have shown the improvement both in sign and symptoms of dry eye disease. Some studies have shown that dry eye treatments have the potential to improve the tear osmolarity in absence of any clinical improvement or clinical feature improvements. Others, like use of topical cyclosporin, osmoprotective drops, or other things, may change the osmolarity as well as improve the sign and symptoms of the disease. Osmoprotectants are a group of compatible solutes that protect the cells under extreme osmotic stress, and they balance out the osmotic pressure in the extracellular as well as the intracellular environment, therefore preventing the disruption of the cell metabolism. And they have been shown to be effective, at least in vitro studies, like in cultured human corneal epithelial cells, inflammatory suppressing properties, or they reduce corneal staining, decrease cell apoptosis, and reduce anti-inflammatory cytokines. There are some drops or some companies are incorporating lipid-containing artificial tears, and they are generally formulated as emulsions. They have to restore the lipid layer of the tear film, so used in the management of MGD and lipid deficiency. And these products are System Balance and System Complete. I'm not sure how much of them are available in the Indian market. Phospholipids commonly found in the human tear films are phosphatidyl choline, and the other, which is very long name, so I won't say it. System Balance. It was easier to say that in biochemistry class, but now it's very difficult. It's like a tongue twister. So System Balance tear contains a polar phospholipid, which can potentially restore the lipid layer of the tear film and improve the signs and symptoms of the lipid deficient dry eye disease. And the other one is more of a nanoemulsion and contains nanoparticles of the phospholipid, higher content of other ingredients, and therefore provide a more balanced formulation. Then we focus on the lid abnormalities. So it's very important to pay attention to blepharitis and MGD. Blepharitis you would treat with lid wipes, scrubs, or hot fermentation, topical antibiotics, which may be used to reduce the bacterial overload. And in case of Demodex, Demodex infestation is quite common, especially I'm seeing more cases here in North India. And so using tree tea oil is very, very useful. And then in MGD, the lipid-based lubricants, warm compresses, and physical treatments like forced expression. And now we have good devices in the Indian market. There are some masks like Evolve. There are some other lipid compression treatments which you can provide in the office. And also pay attention to the blinking abnormalities. Some people don't blink enough, especially when they're doing work which needs attention. Anti-inflammatory therapy would be topical steroids, primarily the surface active steroids, non-glucocorticoid immunomodulators like cyclosporin A and tacrolimus. Then inflammatory modulation with systemic and topical antibiotic like tetracycline and other macrolide like azathioprine. But NSAID, I'm not sure that I generally don't use, but this is something is included in the guidelines. Then there are some biologics like lubricin, which is shown to be effective in the laboratory studies, recombinant nerve growth factor, and variety of other such factors like exosome-based treatment. There is a company in America now which has launched a exosome-based eye drops for the ocular surface regeneration and to reduce the inflammation. Inflammation modulation with systemic and topical antibiotics. When needed, we may have to do tarsorrhaphy for conjunctivochlesis, specifically if the immune or anti-inflammatory therapy does not reduce the symptoms, then you may have to do a resection of the redundant conjunctiva. And also in cases of blepharospasm, you may have to treat with injection of botulinum toxin, lid corrections like dermatoclesis, blepharoptosis, etc. And then the major or minor salivary gland transplantation. Those things are very rarely used, I must say. Then this is the management algorithm, which we talked all the things, triaging questions, risk factor analysis, and diagnostic test. And then there are step 1, 2, 3, 4. These steps are not like mutually exclusive that you will do only step 1 first and then go to second. No. In a given patient, you may have to do all of them depending on the condition, depending on the stage of the disease. So the first step talks about primarily educating the patient about the condition, management, prognosis, and what are the modifiable local environmental factors, like in case of computer vision syndrome. In case of a patient who is a lady who is a perimenopausal phase, so telling them about dry eye is not sufficient. You must tell that this is a part of the hormonal changes in the body. And this happens in men as well. Education regarding potential dietary modifications. Identification and potential modification or elimination of offending systemic or topical medication. Open lubricants of various types. And lid hygiene and warm compresses depending on the condition. Step 2, if the treatment given in step 1 is not adequate or the patient does not feel the symptoms are not improved, then consider non-preserved ocular lubricants to minimize preservative-induced toxicity, treat oil for the Demodex infestation, if any, and then other factors like tear conservation, overnight treatments. I typically use ointment at night in moderate to severe dry eyes. And you can also consider the in-office treatments, the LipiFlow and other things, if you have other these devices. And a short course of topical steroid or antibiotic. I prefer only steroids in most situations. I give as a pulse dose. Pulse dose means that you give for 6 to 8 weeks, and then you stop. And if the benefit is there and the dry eye symptoms decrease, then add on cyclosporin or tacrolimus. So 3 would be if the treatment given in step 2 are inadequate, then consider oral secretagogues, which I really don't have any experience of using them. Autologous or allogenic serum eye drops, yes, I have used quite a lot. Therapeutic contact lenses, especially I use Prozlens for last 15, 18 years. This is also called liquid bandage. They're very helpful in extreme situations. And then the step 4 is topical steroids for a longer duration. Amniotic membrane grafts. Amniotic membrane is not done for dry eye. It is done for specific indication like conjunctivitis. Similarly, surgical punctal occlusion like punctal cautery in patients with severe Stevens-Johnson, and other approaches depending on the situation. So, in summary, the various strategies are available for management of dry eye, and we have now in India so many, all the options which are available in the global market are available in Indian market. So, it's a very good news for all of us. The tear film products are so many, choosing them which one for which indication is a very confusing situation. But that's something clinicians need to define their own sort of algorithms. So therefore, DUSE2 report proposed this 4-stage management algorithm that presents a stepwise approach for implementing and management and therapeutic options. Recommendation in the management algorithm may be modified or overlap as required by the clinician based on their local or individual choices and patient preferences. Thank you very much.
Thank you, sir, for a very nice and comprehensive description of the management protocol that we should follow in a case of dry eye. We have many questions for you, but we'll take all the questions after the end of all the talks. And we have the last speaker now, Dr. Namrata Sharma, who will be talking about iatrogenic dry eye, which has been quite heavily emphasized in TFOS DUSE2 recommendations. Dr. Namrata Sharma.
Thank you, Rajesh. And I think my task is very simple because the management etiology and the investigations have all been covered. So I'll be basically talking to you about as to what are the mechanisms of iatrogenic dry eye. So basically, iatrogenic means when it is induced unintentionally by the medical treatment of a physician, and so there may be iatrogenic symptoms, and it can occur because of medications. It can occur because of surgeries, which could be refractive surgery, even could be squint surgery. And drug-induced could be topical or systemic. It can also be contact lens-induced, and all kinds of surgeries, ophthalmic and non-ophthalmic, can cause iatrogenic dry eye. Notably amongst these are refractive, cataract surgery, keratoplasty, and lid surgery. Then apart from this, conjunctival, glaucoma, vitreoretinal, strabismus surgery, even intracorneal ring segments. Cross-linking is supposed to cause dry eye, then botulinum toxin, cosmetic procedures, and the non-ophthalmic conditions are graft versus host disease. Now, in most of these cases, what happens is that either the patients are on the borderline dry eye, and this dry eye condition gets precipitated after these surgeries, or the patient just jumps the fence from being normal to being a dry eye patient. So drug-induced could be because of various allergies, antiviral agents, notably acyclovir, which we use, decongestants. It is always best not to prescribe a decongestant like a nefuzoline with a lubricant because they both are antagonistic in their action. One is causing dry eye, other is relieving dry eye. Then myotics, midriatics and cycloplegics, preservatives such as benzalkonium chloride, topical local anesthetics and topical ocular NSAIDs, all of them will have some element of dryness. More so because these drugs also have preservatives. Then when we come to glaucoma, as such, the glaucomatous patients, they are in the age group where dry eye can occur because they are generally, it is diagnosed when the patients are old. And because of the medication itself, there can be glaucoma, and the prevalence of ocular surface disease in glaucomatous patients is almost 60%. So one has to be careful about these conditions. Then there could be toxic immunoinflammatory reaction because of the drug itself, or patient may be allergic to some component. Then there can be tear film instability because of the preservative which is used in the drugs. Now, the beta blocking agents are most notorious for causing the ocular surface disease. And apart from it, in fact, all of them have an effect on the ocular surface when given for a prolonged period of time. Preservatives are notorious. The most notorious of them is the benzalkonium chloride, and that is why more and more drops are coming out now, even the anti-glaucoma medications which are preservative free. And benzalkonium is a quaternary ammonium molecule with detergent activity, and if you see in the various molecular studies also, you can see that it causes apoptosis, and it causes changes at the molecular level. Then on the ConfoScan pictures also, when the studies were done comparing with and without preservatives, the ConfoScan pictures were significantly better in those cases where preservative-free medications were used as opposed to where the preservatives were used. Now, this is again to show the same thing, that the inflammatory markers are much more where the multiple treatments have been given as opposed to the ones where non-preserved drops have been used. Then contact lens is again notorious for causing dry eye, especially if it has been used for prolonged periods of time, and 50% of the contact lens wearers experience dry eye symptoms as compared to 21.7% of non-contact lens wearers in one study. And you can either have CLIDE, that is signs and symptoms of dry eye, during the contact lens wear, where signs and symptoms did not exist before the contact lens wear, or you can have a contact lens associated dry eye, where the existence of signs and symptoms are there during the contact lens wear. An important thing is that you should use daily disposable. The fitting lenses may contain internal wetting agents. The topical wetting agents can be used while inserting them, and there are special inserts, that is hydroxypropyl cellulose ophthalmic inserts, which have also been advocated. Then the treatment has been dealt by Dr. Sangwan very well, so you have to stop wearing contact lenses. Punctal plugs may help, and this is a bit controversial, omega-3 and omega-5 fatty acids. Then surgeries are notorious to cause dry eye, more so the refractive surgeries such as the femto LASIK and the microkeratome LASIK, less after surgery such as SMILE, then cataract surgery, lid surgery, all of them can cause dry eye. Then dry eye signs and symptoms, they are present in almost 50% of the patients who have had LASIK, and they subside by post-op 6 months. And pre-op dry eye is an important factor which is considered as a risk factor for development of a chronic dry eye symptom after LASIK. Now, this mainly occurs because of the disruption of the intracorneal nerves, because of corneal sensitivity that decreases, which causes decrease in the blink rate and decreased tear secretion, ocular surface damage, and dry eye symptoms. Apart from this, the tear stability is also affected, which can lead to decreased TBUT, and this will be likewise also reflected in the Schirmer values. And if you look at the confocal pictures also, they have very nicely shown that the corneal nerves do get severed when you're doing LASIK, whether femtosecond or conventional LASIK. And these are the pictures of the same over various follow-ups, and they start to regenerate. And at 6 months onwards, the regeneration occurs. Now, PRK would induce less dry eye as compared to LASIK, and SMILE would induce less dry eye as compared to LASIK, and this is attributed to sparing of the superficial nerve fibers. And there are certain risk factors. It occurs more when you've used mitomycin C, more with greater ablation depth, and when retreatments have been done. The treatment again would remain nearly the same, except that you can add topical cyclosporin, punctal plugs, autologous serum can be given, and treatment generally lasts for 6 to 8 months following surgery. Then even keratoplasty can cause the dry eye disease, mainly because all the nerves are severed. and this takes about 1 year for the nerves to regenerate. And this has also been shown in the molecular studies and the studies which are done at the level of the histopathology. And cataract surgery can also cause dry eye. And again, because this is a age group which is older age group, and also because this may just precipitate after you do cataract surgery, and various studies it has been shown to cause dry eye. Then flax and phaco can cause likewise, and ICC and ECC dry eye duration would be much more prolonged because the incisions are larger. And again, risk factors for this have been already described. And long microscopic light exposure is supposed to have adverse effect on these cases. And again, preservative-free lubricants, lid hygiene, topical cyclosporin and topical diclofosol, which is not available in our country, can be given. Then apart from this, other surgeries also like pterygium surgery, squint surgery, lid surgery can also cause dry eye. And even following blepharoplasty, there were dry eye symptoms and chemosis. So one should know about it, one should be aware of it and counsel the patient accordingly. Then glaucoma, vitreoretina, strabismus surgeries and intracorneal ring segments, even collagen cross-linking and botulinum toxin can cause dry eye. Then of course, aesthetic surgeries, Botox is notorious for causing dry eye symptoms, and anything which is cosmetic such as this in the ocular surface can also cause it. Non-ophthalmic procedures are primarily the graft versus host disease, which can cause dry eye, and also Stevens-Johnson syndrome and other conditions where the patients are there for prolonged periods of ventilation. Now, there are a variety of tests for dry eye disease, and although they have been tested for cases which are not iatrogenic, but these have to be also standardized in cases which are iatrogenic. And one has to take prophylaxis in the form of drops, especially those cases which are sitting borderline. And to conclude, iatrogenic dry eye disease is a well-recognized entity and is generally underestimated. And there are different aspects apart from the toxic denervation, tear film instability and inflammation. And treatment should not only be addressing the lubrication, symptomatic treatment, but also the underlying pathology, which could be denervation, inflammation, and other components of the condition which need patient understanding. So thank you for your kind attention.
Thank you, Dr. Namrata, for covering this very important topic very nicely, because there are many factors that are linked with dry eye. One of the factors is, iatrogenic factor, which has been very aptly emphasized in TFOS used to. So we have a lot of questions, and a lot of viewers are there on Facebook as well. So there are questions from there as well. There is one question for Dr. Sangwan. People want to know about the availability of the tea tree oil, and would you like to emphasize on how to use and,
I think this is now commercially available tea tree oil, and it's also available as a shampoo by a company called Evolve, or I don't know the name of the company.
They have wipes also. Wipes.
And they have wipes also. Wipe, there are 2-3 companies.
Yeah.
So the product is easily available now. You don't have to make like earlier. We used to find where we can get that tea tree oil. Now it is available commercially and easily available.
Okay. Then there's one question: when to use pure HPMC and when to use electrolyte based? So there's a lot of stress on hyperosmolarity and role of compatible solutes. So
Rajesh, maybe each one of us can give our way of thinking. How do we choose different agents? I think for a practitioner or for an early career cornea specialist or a general ophthalmologist, very confusing with so many products around, so many ingredients. So I go by a basic principle that whether I'm using tear substitutes as a adjunct to, say, for example, patient with VKC. So where my main focus is anti-inflammatory therapy, but tear replacement is only an adjunct. So in those patients, I'm not going to worry too much about which molecule it is there. Okay. On the other hand, if you have a patient with Sjogren syndrome with staining positive, I'm going to be more careful that I'm going to select something which with the ocular resident time is more. It's going to stay a little longer time. The patient doesn't have to do very often. And third factor we need to keep in mind is the cost of the medication. Many times we forget about what we are prescribing. These are very expensive medications and they have to be used for a longer time. So look into that factor as well. Third, I pay attention to, say, patients who have very severe dry eyes, Steven Johnson, or patients with the GVHB. There, the lubricants again play a subsidiary role, but not as the main. There, I use anti-inflammatory therapy as the main, be it steroid drops and steroid sparing agents like cyclosporin or tacrolimus. And in addition to the oral medication, if any required for the management of their medication.
Thank you. Dr. Geeta, anything you would like to add on, or any way you would like to differ on the use of polymers and your opinion on that?
Yeah, I think Dr. Sangwan has given a very nice outline of, which one to choose when. It also depends on how severe your dry eye is, because if you have a very severe dry eye, then the more viscous formulations might not be very well tolerated by those patients. And so it is the severity of the dryness, it's the frequency with which you have to use the medications based on the severity, as well as whether it is an aqueous deficient dry eye or if it's a evaporative dry eye. You probably want to coat the surface with slightly more viscous lubricants. Based on all these factors, you have to take a decision as to when you will use which.
Rajesh, can I make a comment?
Sir.
For severe, 1 minute, Namata. For severe dry eye now, in our country, we have this Prose lens, which is liquid bandage, available quite easily, manufactured in LVP. So I suggest for people who have severe dry eye like SJS or severe OCP or Sjogren syndrome, GVHD, in those situations, if patient can afford, and this is available across the country in all the big centers, and if you have enough patients, you can also get trained and list your center with LVP for supply. So I think it's very important development in last 3-4 years.
Okay, I've been using these clear lenses for very severe cases of dry eye, and they have done quite well. So, I mean, that is something which
Rajesh, there is a difference between scleral lens and a Prose lens, because of the material, fenestration, and the ability to hold the liquid within the lens.
Okay.
So my algorithm, if I can just share it, I will just share it with you. And it is a very simple algorithm that I follow for dry eye patients. And I just want to share this with you. Which tear substitute, I think, is always the question. So if it is mild, then 0.5% CMC or 0.3 HPMC or carbomere. If it is moderate, it is polyols with or minus gelling agents. And if it is severe, then 1% CMC, hyaluronic acid with osmoprotectants. And if it is still not getting cured, then combination of these can be given. And then one has to go totally preservative free when your frequency increases, and then ointment and gels in the end. So this is just, what happens is that there's a jargon of all these drugs. The medical rep just comes and tells you and you don't know what it is. So this was just to classify the same as to what CMC would be, what HPMC, where all it is present. And then for moderate, you would give, something like PEG or PPG. Then for severe, 1% CMC, which is, present in all these agents where it can be given, or sodium hyaluronate. So this is the algorithm that I follow generally. And of course, there's no single algorithm that one can follow, but this can be just a startup thing. And when your frequency increases, then you have to go completely preservative free.
There's one question regarding mucolytic agent. So, any role of or in which conditions you would like to use? Dr. Bhaskar would like to say something on that.
Mucolytics will probably be useful when you have filaments on the surface. So, if you have a very severe Sjogren's and you have filamentary keratopathy which is associated, then you can give acetylcysteine drops. 20% is available as an ampule. You can just put it in a bottle and ask the people to put it. Normally, for about 4 or 5 days, it should settle down. The other option would be to put a bandage, contact lens, and lubricants, and make the patient more symptom-free as such. Just to add on to the previous discussion in terms of severe dry eye, sometimes, especially as far as HGS and very severe dry eye, even with Sjogren's, when you have a Schirmer's of 0 and 1, punctal occlusion in the form of a permanent occlusion is not as often done as it should, because it makes a huge difference in the comfort. I'm not talking about punctal plugs, we're talking about occlusion either with a cautery or by suturing the puncta closed completely. The moment the puncta closes significantly, there is an improvement in the ocular surface health, both in terms of the patient comfort and in terms of the inflammation that you physically see with respect to the corneal staining and the conjunctival staining in these eyes. In fact, in SJS, most of the time the patient comes to us, the first thing that we look at, if the Schirmer's is 2 or 3, is to basically look at the puncta. And if the puncta is open, we go ahead and do a syringing to make sure that the puncta is otherwise patent and it is draining. Because if you block a puncta when it is blocked at the nasal side, you will end up creating more problems. So make sure that the channel is patent, and then go ahead and block the puncta so that you are able to retain the tears on the ocular surface.
Since we are talking about Sjogren's, in severe Sjogren's, do you think there is a role of these secretagogues, something like pilocarpine? I have personally used pilocarpine in severe cases of Sjogren's, starting with 5 milligram once a day and then increasing to twice a day. Only the risk of headache is there, so that's why we start with 5 milligram once a day.
Severe patients have severe stomach problems also.
Yeah. So what is your
that is the main problem? They can't tolerate it for more than a few days.
I have a few patients who are being followed up, started with 5 milligram once a day and now twice a day, severe cases of Sjogren's, and they improved with that.
I think dose classically is 5 milligrams TDS.
Yeah, but initially if we give TDS, patient complains of a lot of headache.
They don't normally tolerate it. Yes, Geeta?
Yeah,
apart from the side effects that you've all been referring to, most of the times you see that the secretagogue effect of pilocarpine is more evident in the salivary glands than it is in the lacrimal glands. So most of these patients will complain of excessive salivation, but the amount of increase in the tears is actually both clinically and symptomatically very negligible, is what we have seen in our experience over 2 years.
Okay. And then we have, Dr. Namta, you presented about the iatrogenic causes. Now, somebody who is having, hypertension, taking antihypertensive drugs or taking antihistaminics, so what suggestion would you like to give to, and is having some problems? So anything you would like to modify, you would like to say something on that?
So
any systemic drugs causing?
Antihypertensives and antihistaminics, if one has to take, then we'll have to symptomatically only treat these patients with lubricants, because the systemic drugs cannot be stopped. So only the thing is that topical lubricants have to be taken CMC first, and then if it doesn't work, then the PEG or the gels can be taken, followed by sodium hyaluronate. There's nothing you can do to stop the systemic drugs.
Maybe, Namata, you can talk to the physician and see if the other agent, if the eye symptoms are bad, then are there any alternative? So you will work closely with the treating physician.
There's one question regarding role of rebamipide. So any experience on that?
I have no experience at all.
Rebamipide basically was initiated as a gastroprotective agent. It's a mucomimetic. So, extending that same logic to the eye, it was initiated as a protective agent in mucin deficient eyes. And the suspension, preservative-free suspension, which is formulated and available in Japan, is very different from the one that we have available over here, which is, has preservatives. So we're not still very sure about the effect that we see with rebamipide and whether we can actually compare it with what the Japanese have concluded. But some patients do benefit from it. It does have at times a stinging sensation, but the most important thing is the bitterness that it leaves in the throat after instilling rebamipide. But we have not seen that much of a benefit with rebamipide for us to continue with it for patients who do show signs of mucin deficiency.
So just to extend that further, I think there was a study which was done at our center where patients who had gastritis were given rebapamide. Systemic rebapamide, that too not topical, And then they tried to estimate the tear film concentration of revapamide, and they could find, even systemic revapamide in the tears. And they said that, their parameters of ocular surface also got better. But that was with systemic revapamide, not with topical revapamide. It came into vogue, and I don't know, then it just kind of, disappeared. People don't advocate it too much.
There are some patients whom I have used and found out that they complain of some feeling of tightness in the lids, and most of them were not, they did not improve that significantly as we had expected. So it was kind of not a very, very positive kind of a response.
Revapamide, I think, cannot be given as a standalone drug.
No, not as a standalone, along with lubricants. But a few patients, they complained of tightness of lids with use of that. I don't know why. Then there is another question.
Rajesh, there is another thing that I see in patients who are referred is doctors prescribe too many medication.
Yeah.
I think we should avoid using too many medication, too many topical medication, because all those also have some epithelial toxic effect and ocular surface damage. So we must keep that in mind.
Any role of chloroquine?
So dry eye, I think chloroquine has been studied, and one thesis which got completed at last center said that in post-basic eyes, they compared cyclosporin with chloroquine, and they said that chloroquine is equally good, when you compare it with cyclosporin. Of course, that was just a 3-month study. It was not a very long study. Like cyclosporin topical, you can give for years together and nothing happens. So that is something which...
But now chloroquine will go to COVID, not for us.
Yeah.
Yeah, but even in COVID, it's quite sort of kind of controversial whether its use is really used. Then there's a question regarding any dietary recommendations. What is your take on that? Any dietary recommendations for patients of dry eye?
Dream study. Geeta will answer this.
Yeah, so there was such a big hue and cry about omega-3 fatty acids and about the entire pathophysiology and etiology of omega-3 and omega-6 fatty acids and the ratio. But unfortunately, the DREAM study shattered the dreams of omega-3, I guess, in the management of dry eye, because ultimately they showed that 3 grams of omega-3 compared to 1 teaspoon of olive oil in almost close to 500 plus patients in the US study did not show. All of them showed a slight improvement in their symptoms, but finally they attributed that improvement in symptoms in both the groups to having come back and met the ophthalmologist 4 times in a year, and having spoken to the ophthalmologist rather than to the effect of drug per se. As of now, both the DREAM study and the DREAM extension has concluded that there is no role of omega-3 with respect to dry eye disease. But one thing that we need to keep in mind is that this study was conducted in dry eye disease, and nobody has even specifically look at the effect of omega-3 on meibomian gland deficiency. So probably that is one part of the study that we need to keep at the back of our mind when we talk about it holistically and not just rubbish the whole thing. There could be weightage to the use of omega-3 in MGD, but that is something which needs further study.
There is one very basic question regarding how to differentiate. Patient comes with watering and itching, whether the patient is having dry eye or the patient is having allergic conjunctivitis, allergic eye disease. Yeah, Dr. Bhaskar, you want to say?
Basically, the most important thing would be generally if you're complaining of itching with respect to dry eye, most of the time, unless you have a coexisting allergy and a dry eye, your itching is going to be related to your blepharitis or meibomitis. So they will normally say, I scratch my eyes with my finger, whereas an allergic conjunctivitis patient will generally keep rubbing the eyes almost with the entire palm. The second would be in terms of the age that you would see. Allergic patients are probably more on a younger phase. So if you're looking at an allergy with a dry eye, you're going to be looking at a chronic VKC patient with significant ocular surface comorbidity. An elderly patient who suddenly comes, if it's allergy related, it's not going to persist for a long period of time. it's probably going to fluctuate unless there has been a change in his place of stay, or there's any construction activity nearby which is aggravating the itching. So a proper history goes a long way in identifying as to what is the cause for the discomfort. The good thing is lubricant will work both, even in allergy and even in dry eye. But if you understand the reason why the patient is complaining, it becomes a lot more easier to tell the patient and explain the basis. So the confidence that the patient has in you becomes better.
There's one question by Dr. Sunana Malik. She wants to say that what about the unnecessary prescription of lubricants in just about anything?
That's what I said. See, people using post-cataract surgery, post-LASIK, post-every surgery giving dry eye is really overkill. I don't think it makes any sense at all. Then you are not using your skills or clinical skills or as a scientific way of using them.
And a similar question is like, how safe is to use it for a very long period, whether it's safe or not, because people do use it for indefinite period. So,
do you mean the lubricants?
Lubricants, yes, yeah. So more or less, the answer has been given by you that you have to be really judicious in your approach. And
so the only thing is, if they are with the preservative, then of course it's a problem because they will have their own toxicity. And I think Dr. Sangwan mentioned very nicely that you should not be giving too many drugs, because sometimes they are prescribed too many medications and the patients come with toxicity. But if the frequency is increased, then you have to give it preservative free.
So what I tell is, Rajesh, the medicine may not have side effect in the eye or body, but its side effects will be in the pocket.
Yeah.
That's very true. That's very true. And then if you're not judicious enough, then it's not correct. We have many other questions, that are repeat ones. And then there's one question regarding steroid use, whether we should use mild steroids, or we should use the most potent steroids if you're using steroids in cases of dry eye.
So I'm a bit of an atypical clinician, maybe among you all or others. Is I believe that if, say for example, if you have a moderate to severe dry eye, and if you want to break that cycle of inflammation, dry eye, inflammation, all this, so you need to use not very mild topical steroid. I would use very active like pred-acetate, and follow the patient very closely and monitor. And I'll give this therapy as a pulse, like 4 to 6 weeks, as a tapering dose.
Okay.
I quite agree with Dr. Sangwan. I also want to, whenever give it full on. It should be a full attack. It should not be a half-hearted attack, that you give. Geeta is already smiling. I don't know what she has to say, but I feel it should not be a half-hearted thing, fluoromethalon for TDS or fluoromethalon for BDS. Nothing is going to happen. It has to be a full-on attack, and it has to be something like pred-acetate for the dose that it should be given.
But it's important to identify which patient you use.
Patient, yeah, you have
so
to.
Please don't mistake us as saying in every dry eye patient you should be using these.
Absolutely, absolutely. So Geeta, you were smiling, so you wanted to say something.
I totally agree with the both of you. I don't want to be typical. That, I'm going to do the opposite. But the only point that I would like to stress upon over here is what Bhaskar also mentioned earlier, is that unlike the common belief that we all have, and we keep talking about toxic tears or inflammatory tears, and the fear of occluding puncta in these patients will cause an increase in inflammation in these eyes. At times, what we have seen, in fact, we have reduced a significant amount of steroid use in our patients of dry eye by just resorting to punctal occlusion or punctal cautery. And those who wouldn't want to do a permanent punctal cautery, worried about, inciting inflammation, could always go ahead with a temporary punctal occlusion and see the effect before you actually decide on the need for topical steroids in these severe dry eyes. But otherwise, yes, when you do need it, you should use this one.
So there is one question now coming for the role of immunomodulators for cases of dry eye.
I think Dr. Sangwan talked about it. Topical cyclosporin for dry eye did come into the slides. whenever.
So it was, yeah, sir.
So what I follow is that how do I know which patient would need topical cyclosporine or tacrolimus? If the patient, I generally don't use these things in the mild dry eyes. Moderate to severe dry eye, not associated with other systemic conditions. So I would use typically if they need pulse therapy of topical steroids, say more than 3 times in a year. Then I would think of, and they get benefit with the topical steroids, but I do not want to use for a long time because of the side effects. So then I would start using a topical cyclosporine and or tacrolimus ointment as a steroid sparing strategy.
Okay.
And when I taper off the steroids.
So we do have many more questions, but there's one very pertinent question, and that is please give carry home message for comprehensive ophthalmologists. So I would like all of you to, give carry home message to comprehensive ophthalmologists before we wind up. So we begin with Dr. Sangwan, sir.
So in short, Rajesh, you want us to conclude the session so I can ask carry home.
My message is don't overuse these medicines. Do not use too many agents, and try to understand the rationale and listen to the patient.
Okay. Yes, Dr. Namrata.
So I think what I would want to say is that when you're using these lubricants, use them judiciously. Most of us, in general, I'm not saying most of the general ophthalmologists, but generally don't use a cocktail of because MR has told you, so don't use a cocktail of 3-4 lubricants. It's of no use. It is best to rationalize the use by knowing what is the stage of the dry eye, whether it is mild, moderate, severe, and which agent to use, which he's already done with, or how many 3-4 agents he's using. So sometimes you may even have to withdraw. So that judicious algorithm has to be there in your mind before you prescribe these medications.
Dr. Geeta.
Yeah, I would say a good history taking, listen to your patient, build a good rapport with your patient, because these are the patients who usually go doctor shopping, and you have stick to the investigations that you do. It might just be a Sherman's, it might be cleaning, it might be looking for tear breakup, but do it consistently at every follow-up visit. Don't fall into the habit of pen or just prescribe lubricants based on the last MR who's walked into your clinic. Have some kind of system that you follow so that you can follow up these patients and have a routine that you create for your set of dry eye patients. And like the others said, do not over-medicate these patients.
Dr. Bhaskar.
The only thing would be, most of the time we operate patients who are elderly, and they are all are either probably pre-dry eye state or they are already having dry eye. We normally don't look at them when we look at a cataract, and we directly go ahead and operate. And then after that, the patient has a problem. So it's always better, all patients, when you evaluate, put a drop of fluorescein in the eye, evaluate the tear breakup, fluorescein tear breakup. That will also give you an idea about the tear meniscus height. It gives you an idea about the staining. Just this one test, if you do in all your patients as a practice, you will identify any patient with a borderline dry eye who needs further evaluation, or he needs to be he needs to be explained about the protocol in terms of post-operative care, in subsequent visits in a lot more detail. So at least you are establishing a baseline with respect to where you start, especially in premium lenses or any cataract surgery for that matter. So all patients do a fluorescein test as a part of a routine slit lamp evaluation.
That's a wonderful message. Do a breakup time to see, and it's a very simple test to do. So I would like to thank all the speakers, Dr. Sangwan sir, Dr. Geeta, Dr. Bhaskar, and Dr. Namrata for this wonderful webinar. I would like to thank the IT people. I would like to thank Intod for supporting this webinar. And thank you very much. I thank all the people who connected with us.
Thank you.
And
I think we should also thank the Tear Film Ocular Surface Society, who let us do this, especially Dr. David Sullivan, under the aegis of TFOS Society, which is an international society, which is the society which gave the dues to guidelines to us, and we've done it in collaboration with them. So we are thankful to them for having allowed us to do this. And also Intod, who are the brand ambassadors of brand ambassadors in terms of sponsors from the TFOS Society in India, and Rakhi and Kripal, who are there at the AIOS office, who are coordinating this.
Fantastic job, everyone. Thank you.
Thank you.
Thank you.
Thank you.
Thank you.